Well, good morning, everyone, or almost afternoon. Thanks so much for joining. My name is Graham Schwarz. I'm from the Cleveland Clinic. We've been involved in the surgical treatment of lymphedema for over a decade. And it's really an honor to be here as part of this LE&RN webinar series during Breast Cancer Awareness Month. And we're really distinctly honored, in fact, to be designated as a LE&RN Comprehensive Center of Excellence. And this has been going on for a number of years. So that partnership is something that we really, really, truly value. I think it's really amazing to see the advancements in awareness and advocacy, and I think this is partly due to actually LE&RN's efforts, and we really value a lot what they do for our patients. So it's truly remarkable, like I say, to kind of understand the advancements in both awareness and advocacy, but also understanding the actual disease lymphedema. Additionally, our approaches to surgical prevention and treatments have changed by a lot over this last decade, and things have in fact quite rapidly evolved. I'm particularly excited about a lot of the technologic developments that have the capacity to help us better care for patients with lymphatic disease and help us to prevent lymphatic disease. And robotics is one of these. So in addition to kind of broadly discussing lymphedema and what it's all about and its mechanism, I'm going to talk a little bit about how robotics and technology can play a role in its prevention and treatment. And so I want to thank MMI for sponsoring this webinar. They are the maker of the Symani microsurgery robot system. While I have no real disclosures that are particularly relevant to this talk, I am a user in my clinical practice of the MMI robot, and I'm using it quite frequently. So let's get started. Lymphedema, I think, as everybody is aware, is a critical problem. Millions of people are affected by this condition, and it's really currently thought to be incurable, though hopefully that will change. It has many long-term health implications. It can affect patients' function, aesthetics, and self-image, their overall quality of life, and it can exact a tremendous financial burden on patients and even on the healthcare system at large. So why does lymphedema occur? Well, lymphedema results from a mechanical or developmental disruption to lymphatic transport system. So what happens is, for some reason, whether or not it's a blockage or it's underdevelopment of lymphatic system, there's impaired lymphatic transport, and this leads to increased hydrostatic pressure in the lymphatic system. And so what happens is that lymph fluid, which lives in these this circulation of lymph channels, leaks into the space between your cells and between the tissues. And this ultimately leads to an inflammatory response, fibrosis, fat deposition, and can ultimately lead to issues with immune dysfunction and infection. So many people are affected by this condition, and the way that it manifests is typically a swelling or discomfort. Folks might notice tightness, heaviness, aching, burning. It's unusual. I just want to add that it's quite unusual to have sharp pain that's related to lymphedema, and if this exists, and particularly in the cancer patient, the breast cancer patient, if somebody has sharp pain in their limb, that needs to be further investigated. And it can't be just generally attributed to lymphedema. There could be issues with nerve supply or scar tissue and these kinds of things. Folks can experience problems with range of motion. And from an exam perspective, if somebody is being examined in the office, examined in the office, they can demonstrate what's called edema, which is a swelling. This edema can be pitting. It can take the form of non-pitting. And usually when that happens, that means that there's an accumulation of subcutaneous fat or scar tissue in addition to fluid accumulation between the tissues. Ultimately, this can lead to an irreversible enlargement in the area, whether it's in the limb or another area of the body. And it can further produce skin overgrowth, scarring of the skin, hyperkeratotic changes to the skin, warty overgrowths. And all of this can be coupled with problems with cellulitis or infection, drainage of lymph fluid from the skin itself, and even in the most severe circumstances, lead to malignancy related to the actual lymph system itself. So we're going to focus, a lot on sort of breast cancer-related lymphedema, but lymphedema can occur with many different kinds of cancers. It can occur, obviously, from a congenital issue too, but I think in the Western world, what we see most commonly is lymphedema that is generated by treatments that we have actually provided to patients to help them cure their cancer. So in patients treated for breast cancer, up to 30%, even more, can go on to develop lymphedema. Usually, most of this lymphedema, if it's going to occur, will occur in the first 2 to 3 years after treatment. We can see high rates of lymphedema in melanoma surgery and gynecologic cancer surgery and sarcoma surgery as well. Let's talk a little bit about the risk factors specific to breast cancer. Now, lymphadenectomy, which means removal of lymph nodes, is really the most high impact risk factor. And so the more lymph nodes that are removed, typically the higher chances that you have to develop lymphedema. There's been a trend toward axillary sparing tissue or lymph node sparing tissue removal during cancer surgeries. And so this kind of has been exemplified by the sentinel lymph node biopsy. And when we do sentinel lymph node biopsies, only 2, 3, 4 lymph nodes are maybe removed. And this still confers a risk, but not quite as high as if you were to remove all of the lymph nodes. Things like radiation therapy, postoperative seromas, increased body mass index or obesity, certain types of chemotherapeutics like taxane-based chemotherapeutics. These can all contribute to risk for developing lymphatic dysfunction. Folks also have can have a genetic predisposition, which can lead to the development of lymphedema as well. So what are the mainstays of treatment for those folks who develop limb swelling and lymphedema? Well, generally they're focused around non-surgical therapy like compression, massage, exercise, skincare. And when you sort of incorporate these together in a systematic way, that is sort of what complex decongestive therapy entails. First, there's typically an intensive phase to try to remove as much of the fluid as possible, then a maintenance phase, which is really characterized by maintenance of compression and maintenance of that aggressive decongestion. Adjunct maneuvers can be added to these therapies like external pumps, pneumatic compression pumps, and these can be quite effective in reversing swelling and even halting the process. Sometimes it can reverse things to the extent where people go back to baseline. But in certain situations, despite best efforts at these treatments, folks still continue to progress. Their limb continues to swell. They continue to spend hours and hours a day trying to manage their lymphedema, and it really impacts on their quality of life. And so this is where surgery comes in. And so with surgery coupled with therapy, we can do several things. We can reduce the size and weight of the affected area. We can increase mobility of the area that's affected. We can improve the ability to decongest the area. We can reduce time for patients in compression, and we can oftentimes reduce episodes of infections. And surgery treatments come in a set of varieties. And really kind of there's two main categories. One is where we're actually actively trying to remove sort of solid tissue or fat and scar tissue that might accumulate due to the inflammatory process and growth factors that are elaborated during lymphedema and lymphatic dysfunction pathophysiology. And then there's physiologic procedures. And these focus on really rerouting the plumbing or trying to get the lymph fluid to go into the bloodstream where it's intended to go. However, generally we'll see a blockage, and we're trying to divert the flow around the blockage. Sometimes we need both of these kinds of treatments in order to produce a desired effect, because some patients have both accumulation of fat and scar tissue, and they have accumulation of fluid. So when we can strategically use these treatments together, we can really get maximum effect. It's really the physiologic procedures where we see robotic assistance come into play. And I'm going to talk about that a little bit more in a few minutes. So who's going to benefit most from surgery? Well, really, it's the person who's generally pretty healthy, non-obese. And if we see health issues prior to any surgical consideration, we'll typically optimize them from a medical standpoint. We have supervised weight management programs, which are effective for our patients, getting them ready for surgery. And in doing so, also typically improves their lymphatic function, because we know there's a link between obesity and lymphatic dysfunction. There needs to be really clear signs of lymphatic dysfunction. In other words, there could be many reasons for limb or area swelling in patients. And so we really have to have a good diagnosis and understand that the swelling that we're treating is really swelling related to lymphedema. Sometimes, in fact, veins or venous disease can cause problems with swelling. And so we like to have that treated as best as possible, or at least have a good coordinated plan with our vascular medicine and vascular surgery colleagues to manage that through the surgical treatment of lymphedema. We have to coordinate with our therapy teams in order to optimize the region. We like to operate on areas that are maximally decongested and not swollen and ready for surgery. This will promote good healing and improve the efficiency of our surgeries. We don't want any evidence of rapidly progressive malignant disease. Certainly as part of any new patient visit that I see, we're always, taking a complete oncologic history and making sure that we're not missing anything, or a new onset of cancer or cancer recurrence. Now, that being said, there are a lot of people out there who are living with stable cancer diagnoses or stable metastasis, and they're on sort of long-term treatments. And so I think our thinking has shifted a little bit on this. I mean, patients' longevity is thankfully increasing, and they shouldn't have to be limited, and their quality of life shouldn't have to be affected by lymphedema if they have it. So I think in many cases we can safely intervene with surgery in order to improve folks with metastatic disease quality of life. People need to have good compliance to their therapy regimens. This is really part and parcel of a successful response to surgery as well. So what surgery do we choose? Well, it's a bit debatable, but I think by and large what we like to do is focus on the greatest source of disability and what's causing the most diminution in quality of life. What regional areas are most affected? What are the goals and expectations for patients? We try to elucidate kind of, is the lymphedema process mostly a fluid-based process or a solid-based process, and what's more important to the patient. We do testing called ICG lymphography, which is a fluorescent guided imaging technique, and we try to elucidate where patterns of dermal backflow are. This can kind of tell us a little bit more about the lymphatic, state of the lymphatic system, and also help us target areas to treat more effectively. Is there a need for scar release based on prior cancer surgeries or radiation? We can often do that as part of the surgical treatment. And are there other reconstructive needs? Sometimes patients require breast reconstruction, and we can sometimes couple this along with staged lymphatic surgery. So when we are evaluating a patient, again, really important to talk to the patient, learn about their history, and do a good physical exam. We do a variety of measurements, looking at baseline limb volumes and checking bioimpedance spectroscopy to understand kind of where we're starting, to make sure that we can demonstrate progress in our treatments and understand where we need to target along the limb or region of the body that's having problems. Typically, our initial approach is going to involve imaging. Again, I touched on ICG lymphography. This is a real important aspect of the planning for lymphatic surgery. We oftentimes use ultrasound, not only to look at venous disease, look for blood clots, issues with strictures or obstructions in veins, but also we're increasingly using it to map out where veins and lymphatics are. We will oftentimes get MRI tests to differentiate between fluid and fat and scar tissue, again, helping us to target and plan sort of the appropriate staging of surgery. So lymphedema surgery, again, falls into kind of two big categories, right? There's a tissue reductive category, and then there's the physiologic category, or fixing the plumbing category. So as it relates to removing volume, a solid volume from a limb or an area, usually we use liposuction, and we're targeting the lymphedema lipodystrophy and the fibrosis, and we're trying to remove that. Sometimes we need to remove skin too. If there's extra skin that develops after we remove the underlying tissue, or if the skin is particularly damaged, sometimes we'll remove it. This can be done with a variety of methods. And again, it's a little bit debatable which is the best, but they all seem to have good effect. So what we're trying to do, what are our deliverables here when we're doing volume reduction surgery? Well, typically we can produce an immediate improvement in size, an immediate improvement in cosmesis and in physical function. And I think that there's some evidence to suggest that this may even improve lymphatic function. At the end of the day, though, the plumbing isn't fixed. So folks really need to be diligent about keeping compliant with compression. And if they do so, there's good evidence to say that there's only very limited recurrence. So let's shift gears to physiologic procedures. And we'll talk about lymphaticovenous bypass, otherwise known as lymphaticovenous anastomosis, or LVA. And these are procedures that are designed to relieve lymphatic hypertension. Generally, it's been shown in the past that these kinds of procedures work best on early stage lymphedema, when the lymphatics are not too scarred and they're generally functioning. But I think there's some shift in this thinking. I think we're starting to loosen up kind of our approach to only focusing this treatment on early stage lymphedema patients. Ultimately, what we want to do is we want to restore the anterograde flow of lymph into the bloodstream. These procedures are minimally invasive and typically will make small incisions at multiple sites on the affected limb or in the trunk. And we'll use what's called super microsurgery technique. So we're using highly specialized instruments and very, very tiny suture on lymphatic structures and vein structures that are on the order of about 0.3 millimeters to 0.8 millimeters. And so this is sort of how we get started in the operating room. You can see on your screen left that what we're doing is we're performing ICG lymphographic mapping. We're injecting this fluorescent dye called ICG, a non-toxic dye, which is picked up by plasma proteins, and it flows into the lymph system and courses up in this case, in the arm. This is a patient, in fact, with breast cancer-related lymphedema. And what we do is we translate those imaging mappings onto the skin with marker. And then what we'll do is we'll oftentimes use an ultrasound to map where veins are in proximity to usable lymphatics. And in that way, we can make strategic localized incisions where we have a lymph channel that we want to bypass into a small little vein. We're sort of limiting our searching around in the arm to find these very tiny structures and making surgery more efficient and impactful. So this is a video showing an example of lymphaticovenous bypass. If you can make it out on your screen, these sutures are very, very tiny. They're 12O sutures. The boxes that you see in yellow, in that yellow background behind the lymph channel and the vein are about a millimeter in diameter. So this connection is about 0.4 millimeters in diameter. And what you can see here is the lymph channel on the left of the screen going into the vein on the right side. We'd already made a second or a first connection, I should say, at the top of the screen here. And then what you can also see on screen right is the final connections in relation to what are very tiny silk suture to give you a concept of better concept of scale. And then we'll confirm that we made good connections by injecting this ICG dye into the skin and watching the transit of the fluorescence through the connection that we made. So another means of a functional or physiologic procedure is to directly plug in a vein into a lymph node. This is actually a very old concept, but it's experiencing somewhat of a resurgence. The idea here being that there is a convergence of lymphatic channels that are going into a single lymph node. And if that lymph node is engorged or under hypertension or hypertensive, I should say, making a little hole actually in that lymph node and connecting a vein to it can be a fairly powerful way to have that lymphatic fluid bypassed into the venous system. So let's shift to robotics. Robotics have been now on the scene in surgery for many years, since the 90s. 8 million procedures have been performed, but it's only recently that robotics have found their way into microsurgery and specifically super microsurgery. And this is really because instrumentation, the delicacy of the instrumentation has not really been there. However, now there are some systems such as the Symani system by MMI that has very, very fine instruments capable of making very, very precise movements. And it's the precision and the dexterity of these systems that allow for better consistency over our surgical bypass connections. We're able to eliminate tremor using this technology. We're able to kind of scale motion from large hand motions to very, very tiny submillimeter motions. And ultimately, the hope is that this translates into safety and efficacy for our patients in terms of our lymphatic surgeries. These kinds of technologies can enhance our access to hard-to-reach anatomy. They can improve ergonomics for our surgical workforce, and ultimately that can translate to providing this service to many more patients, because there are more surgeons able to do it. I think one thing that's particularly exciting to me is the concept of telesurgery and the fact that one day we may see the ability to provide these kinds of highly technical procedures to patients at a distance who may be in an underserved area or an austere region. Ultimately, I think we're going to see improved outcomes, and we're working toward that. There are some considerations about efficiencies and cost, and those are being worked out. But I think that this is very exciting. So I'd like to share a couple of cases that we have done in the recent past using robotic technology, physiologic procedures. This is an interesting case that I'm going to share with you about breast cancer-related breast lymphedema. Not a condition that gets a lot of press, but it is actually pretty prevalent. A lot of people are, a lot of survivors are out there who suffer from this condition. So let me tell you the story of this 41-year-old female who came to me about a year and a half after she underwent breast conservation therapy. She had only a sentinel lymph node biopsy, but had a lumpectomy, radiation, sentinel lymph node biopsy, and then adjuvant taxane-based chemotherapy. So she presented with a swollen right painful breast with what's called peau d'orange, which is really a tight skin edema. It looks like the peel of an orange. And this really precluded her from doing a lot of the things that she liked to do and really living her life. So what we decided to do together was investigate a little bit more. So we went and we did our ICG lymphography, and we saw that in addition to having a lot of dermal backflow and reflux of the lymph into the skin because it was being blocked, there were a few channels that appeared that we could bypass and create some lymphatic outflow for the breast. So you can see here that there are actually two incisions, one of which is the actual lumpectomy incision, and one is the lymph node biopsy. And if you look at the screen ICG black and white image to the right of your screen, you can see a linear pattern, and that's sort of where we aim to target for our bypass procedure. So what we did was we utilized a robotic-assisted procedure, robotic-assisted lymphatic-venous anastomosis, and we performed two connections. We did so strategically after performing the ICG and co-locating the dilated lymphatics with veins underneath the skin. We used the Symani robot, and we used an external microscope called an exoscope, which provides display on a digital screen. And ultimately, we're able to construct patent connections from the dilated lymphatics into a vein, which you can see in your screen here. And this is sort of a diagram on your left that looks at the scale, right? We're making a very tiny 1.5 centimeter incision. We're performing these very, very small, precise connections. And the benefit of using robotics in this particular scenario are that there is really a lot of obliquity, meaning it's very hard to actually position for the surgeon their hands in order to perform super microsurgery in this location. So the fact that we're able to use the robot to kind of take that out of the equation really facilitated our ability to perform this procedure. So immediately we noticed that the breast got much softer. There was much less edema, and within a day, the patient's heaviness and achiness really resolved. And this was sustained and continues to be to this day. When asking her to fill out quality of life forms, which we do standardly pre-op and post-op, we noticed that the LLIS, or quality of life score, diminished from 61% to 15%. And again, this was sustained. This signifies a significant decrease in disability. And she will tell you herself, she feels quite amazing. So here's another interesting case vignette. This is a patient with breast cancer-related lymphedema of the left upper extremity. It's a 48-year-old female who 3 years after left breast cancer, treated with mastectomy, axillary lymph node dissection, post-mastectomy radiation and chemo, developed lymphedema. And when I met her, she was in ISL stage 2B, and she had this mixed solid and fluid picture of her left arm, where she had this process affecting her hand, her forearm, her upper arm, and she couldn't fit into her shirt. She couldn't flex her elbow. Despite being highly compliant, she visited her lymphedema therapist regularly, was maximally decongested, but it was clear that she had lipodystrophy. And we did an ICG test on her, which showed quite a bit of dermal backflow throughout. So we planned a staged lymphatic reconstruction. first to impact on the solid aspect of her lymphedema process, and then, in the future, hopefully, impact on her fluid component. So in her first stage, we went to the OR, we removed 1,500 cc's of lymphodematous fat and scar tissue. She had an immediate improvement in her function, clothes fitting, cosmesis, heaviness. She was really quite happy with this. She still required a class 3 garment and would pump, but her life was much better. But she was still motivated to move forward to see if we could make improvements in this fluid aspect. And so we repeated the ICG about 8 or 9 months later, and we noticed that her ICG patterns, in fact, improved. She now had a stardust pattern and linear patterns, which are jargon just to say that there is slightly less dermal backflow into the skin, and either there are new lymphatic pathways that emerged, or we've simply uncovered lymphatic pathways that were buried within the scar tissue and fat through the liposuction. So in this case, we utilized a robotic-assisted LVA. We started again by performing ICG and ultra-high frequency ultrasound lymphatic and vein mapping to really strategically isolate where we're going to make our incisions. And then we performed 3 different lymphatic-venous anastomoses at 2 sites. One was the side of a lymphatic to an end of a vein, and 2 were end of lymphatics to ends of veins. And I want to just point out here, we use the robot. And you've seen it before in the prior video, and you'll see it again in a future video that I show. There is no tremor here, right? The movements are highly precise. And when you're operating at this scale, sometimes you might have had a bad day, or maybe you had too much coffee, or maybe you worked out in the morning and your hands are a little bit shaky. Well, it's interesting the precision that the robot allows for. You can see the very, very smooth and scaled movements. Essentially, this is what the promise of this technology is. So when we completed these different connections, we were able to see immediate on-table decongestion of the arm, which is always, highly promising, and I think a good indication that your surgery is going to make improvements in the quality of somebody's life. And in fact, it did immediately post-op. She noticed that her arm was softer and more pliable. The skin was more pliable throughout her upper arm or forearm. She did not require any additional pumping, which she had been doing. She's scheduled now for garment refitting, and we're planning to wean her compression. I am not sure that she'll ever be free from compression, but certainly I think we'll be able to give her increasing holidays from her compression. She's quite happy with this. So let me shift gears to vascularized tissue transplants. These are a little bit different in the sense that we're transplanting lymphatic tissue from one area of the body to a separate area of the body with the hopes that it's going to stimulate new lymphatic growth, potentially absorb lymphatic fluid, and provide an immunologic center in the area where that immunologic center is potentially compromised. We can borrow this tissue from a number of different areas, from the neck, from the side of the chest wall, from the groin, and from inside the abdomen. There are a variety of flaps that are associated with these particular locations. We can use a groin flap, a lateral chest flap, an omental or gastroepiploic flap, or a mesenteric flap, which is borrowing lymphatic tissue from just adjacent to the intestinal region. And the question is, where do you put it? Well, you can put it in, at the site where the lymphedema is most affecting the person, or you can put it sort of in the area where the damage was done, i.e. In somebody who's had an axillary lymph node dissection. In certain cases, we would put these vascularized lymph tissue transplants in the region of the armpit area after we clear out the scar. So I want to just bring back the robotic component here. So some of the robotics we use in lymphatic surgery and lymphatic microsurgery are obviously to do lymphatic venous bypasses, but we can also use robotics in order to decrease donor site morbidity. So in the instance of harvesting a intra-abdominal flap, like a gastroepiploic or an omental flap, typically, traditionally, we would have to make a long incision in the upper portion of the abdomen in order to get the appropriate tissue. But with robotic assistance, we can be much more minimally invasive and improve patients' recovery and pain levels after surgery. So there's opportunity to incorporate this technology in a variety of ways. We can incorporate vascularized lymph tissue transplants when we're doing things like breast reconstruction. Here's a patient who had severe damage from a post-mastectomy or radiation, coupled with left upper extremity lymphedema. We were able to perform a microvascular free flap or an abdominally based own tissue flap transfer coupled with a groin lymph node flap and sort of solve all the problems at once. So do these work? The answer is yes, they do. They improve the quality of life for many patients. This may translate into a variety of things, including softening of the limb, diminished time spent adhering to all of the compression regimens that they need. It may diminish the amount of infections that they're subjected to. And so most everyone derives some benefit. The thing with tissue transplants versus bypass procedures in terms of the physiologic category of surgeries is that typically with the tissue transfers where there is a separate donor site, there's also a little bit of a delayed gratification. If you make a connection with a lymphatic-venous bypass, typically the patient will feel the effect and understand the effect, and the surgeon and the treatment team will understand the effect quite quickly after the surgery. However, with these tissue transplants, it may take 6 months, a year and a half. So we've talked all about the treatment of lymphedema, but wouldn't it be great if we could prevent lymphedema from the get-go and head it off at the pass? There are several strategies to do this, especially when we talk about counseling folks who are going through cancer treatment, like breast cancer treatments. So standard modes of prevention, I think traditionally nobody really cared, but I think with awareness and advocacy, education programs, I think have become more standardized and more important. And these really focus around activity limitations, wearing compression, and so forth, doing exercises. And some of the recommendations are being updated. I think some are outdated, requiring patients to have too many limitations when maybe they should be a little bit more active. But this is a work in progress. Certainly surveillance programs are something that are we're increasingly seeing providers engage in, and hospitals and cancer centers engage in. This can be a variety of things, symptom checks, as well as taking standardized circumference and volume measurements, maybe using bioimpedance spectroscopy for monitoring patients who are at risk. But there are also some surgical things that we can do to try to head lymphedema off at the pass. And so when we look at the breast cancer scenario, there is a procedure called immediate lymphatic reconstruction that we do. And it's a combination and a coordination of procedures. And in this approach, we use axillary reverse mapping to visualize and preserve the lymphatic system. And in order to do this, what we do is we inject some tracer dye, usually a blue or a yellow dye in the arm, just in the area that is draining lymphatic fluid that we'd like to preserve. We work with our breast surgeons to really do a very precise lymph node removal, not removing any more than is needed to be oncologically safe. Our breast surgeons will mark the cut ends of the lymphatics and really preserve as much of the vein system that they can so that we can make these very tiny connections. And then ultimately, we come in and we do the lymphatic venous bypass procedure, much like we talked about previously, although we do it at the site of the lymph node removal. And so this is not an entirely new concept. In fact, it was sort of brought to the fore back in the 80s by Russian surgeons and really popularized by Italian surgeons in the circa 2009 or so. And it's made its way to the United States, and many centers have started doing that. We started doing immediate lymphatic reconstruction around 2016, and we've seen some benefits. And certainly all the early results are pointing to a reduction in risk, but these, again, are early results. So I think while this sort of approach is quite still has a lot of promise, I think we still need to watch and make sure that these treatments are really maximally effective for our patients. I think the main aspects of doing this procedure are that we want to really be able to see what we're doing in the armpit area after the lymph node removal. We want to really understand sort of the post-surgical architecture, if you will, of what's going on. That is predicated on appropriate exposure and being able to see what's going on deep within the armpit after these lymph nodes are scooped away. And we can do that by illuminating the lymphatic channels that are draining from the arm using a variety of techniques, including blue dye, including fluorescent dyes that we've talked about previously. I want to just show a quick another example of how we do this procedure. Oftentimes we'll see a bundle of cut lymphatics in the armpit. And so this is a methodology called an intussusception technique, where we're doing this lymphatic venous bypass, where we're essentially invaginating this bundle of lymphatics into a vein, and again restoring the forward flow of the lymph into the vein system. I'll just point out that even though we're doing this, I think fairly well, you can see the tremor, and this is a difference from when I showed the robotic LV bypass previously. So we'll then typically get a baseline lymphangiogram and just sort of have an understanding of what the transport capacity of the lymphatic system is at the time of the surgery, so that we can monitor things over time and make sure that we're not developing any things that are indicative of lymphatic dysfunction. So this is another good opportunity to utilize robotics. And the reason is because we're in a deep hole. So it's hard to do super microsurgery and operate on a sub-millimeter scale when you don't have a good access and a good exposure. So the idea of being able to come in with a robot and with an external microscope, so you can kind of visualize things really well and be able to perform this sub-millimeter surgery, it really holds a lot of promise for making these connections as successful as possible. You can see me there kind of playing a video game almost, performing this microsurgery in the corner of the picture. So I think all in all, it's really important that when we talk about breast cancer related prevention and treatment, we have a coordinated interdisciplinary approach. And this is kind of how we approach things at the Cleveland Clinic. It's really important to have a great collaboration with your breast and surgical oncologists and your reconstructive surgical teams. Important to develop easy lines of communication between your oncology rehabilitation teams, your certified lymphedema therapists, and your surgical teams. We obviously coordinate with the other multidisciplinary treatment teams, like our medical oncology teams and our radiation oncologists, to see if we can really optimize care with attention to not damaging the lymphatic system. or damaging it to the least extent possible. Our survivorship teams are really important for monitoring patients for lymphatic dysfunction and for referring patients when the time is right. And obviously, we work closely with our vascular medicine colleagues on optimizing treatments for patients with lymphatic dysfunction. So future horizons. What do I see if I'm holding a crystal ball? I think that all in all, we're going to continue to see the evolution of technologies. We're going to see improved imaging, and this is going to lead to improvements in our understanding of lymphatic anatomy. I think it's going to guide how we do our preventative treatments and even our therapeutic treatments. I think we're going to see improvements in our imaging technologies, being able to use multiple different fluorescent tracers. Obviously, we'll see robotic microsurgery and super microsurgery increase in usage, refiner techniques in preventative surgery. And we're starting to see a lot of exciting stuff going on in the head and neck and in the central lymphatics, which have both been areas that have been relatively understudied. There's some great work going on in tissue regeneration, tissue engineering, and certain tissue scaffolds for lymphatic regeneration. There's some discussion about how these techniques can be applied to neurodegenerative diseases. And I think we'll see also, as in everything else, artificial intelligence and machine learning sort of improve our ability to predict risk and help us generate better decisions for targeted treatments for our patients at risk and who have lymphatic dysfunction. So some final thoughts. I think that therapy is the mainstay, but surgery plays a key role in the multimodal treatment of lymphatic dysfunction and lymphedema, and specifically in breast cancer-related lymphedema. I think you've seen here and will continue to see new paradigms develop for the treatment and prevention of lymphatic disease. Robotics, I think, has a lot of promise for improving consistency, which may translate into better outcomes and ultimately improved access to these types of procedures for our patients. And I will just stress that it's really multidisciplinary collaboration that's essential in order to maximize both our clinical outcomes and our quality of life outcomes for our patients. With that, I'd like to thank everybody for listening and joining today. I'd like to thank LE&RN for the opportunity to talk today. I'd like to thank MMI for their sponsorship. I'd like to just give a quick plug. We had a great robotics in plastic and reconstructive surgery conference back in August with the intent to do that again. So if anyone's interested, please reach out. We're going to be planning our next conference soon. I'd like to thank my team, particularly Burke Osman, who's our postdoc research fellow, Sonia Pandy, who is our super microsurgery fellow, and the rest of our lymphatic team and our lymphatic therapy team. Thank you so much. And I think we will take some questions now. First question is, in stage 2 upper limb lymphedema, do you prefer suction-assisted protein lipectomy and LVA at the same session? I personally do not prefer to do LVA and liposuction in the same session. I think that if you're separating them regionally, perhaps it's a good idea. But combining the two, not only do I not love the sort of inflammatory response and the bleeding, subcutaneous bleeding associated with the suction-assisted lipectomy at the same time as doing a very, very delicate microsurgery. But actually, the practical matter is that you are doing a lot of work with your arm when you're doing a liposuction. So do that, and to then do a super microsurgery procedure can be quite challenging. Now, with robotics, maybe that'll take that tremor aspect out, but It's not something I would do. Second question is, how many patients have undergone bypass or transfer, and what percentage of them have been successful? Have you published on this? There are a lot of publications in the literature on this. Thousands and thousands of patients over decades have undergone these procedures. I think we're getting increasingly better at producing consistent results. I think that with training and better instrumentation, I think we're seeing that we're having great success. Also, patient selection is highly important. You can't choose a surgery just sort of out of the blue. I think you have to be very intentional about the surgery that is chosen with the patient, and really target what the patient's concerns are. Let's see. How long is the surgery if not associated with breast reconstruction? After the surgery, how long is a patient recommended to do decongestive therapy? Well, it depends on what surgery. It depends on what surgery it is. So, the varying types of surgery have varying lengths of time. And it also depends on the severity. So if you're doing a surgery, let's say a volume reduction surgery with liposuction, if it's a portion of an arm or an arm, that may take a couple of hours. Whereas if you're doing a tissue flap transfer, that can take multiple hours. It could take 4 to 6 hours, just the same as with LV bypass. Depends on the extent to which you're doing. As far as decongestive therapy, we're of the mindset that really doing decongestion and surgery are synergistic. It's not one or the other. I think that we hope that when we apply surgery, we can decrease the amount of compression and decongestion that patients need to do over time, but it really is patient dependent. Let's see. You recommend limiting activity with patients without lymphedema. I do not. I think exercise is generally good. There's a lot of conflicting data in the literature. I think some of the recommendations that used to be given are outdated. And I think that is being studied currently and bears further study. For example, doing a blood draw in an arm or occasionally doing blood pressure measurement in an arm really shouldn't there's no good evidence that it predisposes to lymphedema. Let's see, average time patient is under anesthesia for these procedures. Again, depending on the type of procedure, it could be anywhere from 3 to 6 hours, depending on what needs to be done. Is robotic treatment available in Canada? I am not certain about that. Perhaps it is. I'm not sure if there are any microsurgical robots available in Canada to date. Thank you for addressing breast lymphedema. This is the first I've heard of surgery for breast lymphedema. Do you see patients that have lymphatic surgery of the extremity that have overflow improvement in breast lymphedema? The answer is yes. There are folks out there who believe, in fact, that distant areas can improve after lymphedema therapy. I don't think it's been studied widely, but I am increasingly encouraged that we can treat breast-specific and trunk-specific lymphedema by doing surgery actually in the breast or in the trunk with these types of procedures. Clearly, we've had some success as I presented here, and I think it bears more exploration. It's pretty a pretty undervalued condition, and I think deserves more attention. What is required? What is required for referral for evaluation of breast cancer-related lymphedema? Well, what is required? There's no specific requirements. I think that I think that if you are concerned, I think go see your oncology doctor or your carrier. Hopefully you have a multidisciplinary care team, but if you don't, maybe see your oncologist. Get a referral to a certified lymphedema therapist. I think that's really always the best place to start. If there is, a reason to seek additional treatment because that's not effective for surgery, referral can always be provided. And you can certainly reach out to us at the Cleveland Clinic or at one of the many LE&RN centers of excellence in order to get more information. Let's see, how do I go about finding where I can find imaging done to evaluate my post-breast cancer lymphedema in South Dakota? Yes, yes, there are surgeons at Mayo Rochester who do these procedures. If someone had a lymph node transfer to the forearm, does that disqualify them from having a liposuction procedure later on? It does not. In fact, I've done it myself with some of my patients, and it can be quite effective. My thinking has changed. I used to do these lymphatic flaps on all patients as a first strategy, but just like we evolve, everybody evolves. My practice has evolved. So if we're going to do a volume reduction procedure, I'll usually do it first, and then I will do either LV bypass procedure or a lymphatic tissue transplant. And increasingly, I'm doing the LV bypass procedures even more commonly than the lymphatic tissue transplants. But you are definitely not precluded from having that. Let's see. 14-year triple negative breast cancer survivor. I have some severe lymphedema due to over 16 lymph nodes removed from my left arm following lumpectomy. Would you be a candidate for this surgery? The answer is quite possibly yes. We have to look at you holistically. We have to sort of look at your health. We have to look at sort of the areas that are affected, but for sure, an evaluation is warranted. I think getting a referral to one of the again LE&RN centers of excellence that has a surgical apparatus, I think that's probably a great way to go. Let's see, there's a lot in the chat here. I'm going to just go to the chat for a second and see what's here. I see that Dr. Borson is on the chat. Thank you so much, Dr. Borson, for being part of the audience today. And your questions are, as you are an expert and sort of the pioneer in suction-assisted lipectomy for lymphedema, your question is, what are your long-term outcomes in reducing excess volume with suction-assisted lipectomy without LVA? Our follow-up is not quite as extensive as yours, as you have decades of terrific follow-up. I think generally it's been very good. And obviously, suction-assisted lipectomy can be extraordinarily and immediately impactful for patients. I have seen recurrence, and I don't know if this relates to compliance or just progression of disease, because you're not ultimately fixing the stasis problem. and you're not necessarily providing a solution per se for lymphatic hypertension. But I've seen it both sustain, but I've also seen lymphedema progress and recur. I have seen progressive improvements when we've added LVA to the situation. So we're ultimately kind of taking care of both problems. But I thank you for your question. Obviously, you've had a long-term success with suction-assisted lipectomy alone. I think these are not mutually exclusive. I think they're complementary procedures. Question about whether or not we excise skin. I personally do not always excise skin. In fact, we typically, if we're going to do that, I will usually do it in a staged fashion, unless it's overt, stage ISL stage 3 overt skin excess and cutaneous changes or localized areas of lymphedema. Usually we'll get some good contraction of skin with appropriate compression. Let's see. We have a participant from India, patient, a breast cancer survivor, grade 2 lymphedema, now diagnosed with metastasis, undergone chemo, PET CT showed improvement, but has grade 3 lymphedema, currently doing CDT, using LymphaTouch, but poor improvement. What else can be done? I think if the disease is stable, one of these procedures can be potentially offered. Now, I think one has to take into consideration if somebody is being maintained on a chemotherapeutic, what's the safety of pausing the chemotherapy. Let's say they're taking oral chemotherapy to maintain their sort of their stable metastatic cancer diagnosis. Depending on the sort of lymphatic procedure you choose, that requires a certain amount of healing. And what is not good is the combination of chemotherapy and its impact on healing. So you have to be cognizant about whether or not you can offer somebody one of these procedures safely without impacting their longevity from their cancer treatment. But certainly it can be entertained, and certainly we have patients with stable metastatic disease, and we're able to improve the quality of life with some of these types of procedures. Okay. Are there standards in the number of anastomoses made in order to LVA to be effective as surgical decongestion? That's an interesting question. And I think that that is an area that needs to be studied. Just as purely anecdotal, I think that it's more strategically where the LV bypasses or LV anastomoses are performed, rather strategically where they're performed and what sort of lymphatic region is being addressed, rather than the total number. Because if you're doing many lymphatic venous anastomosis in the wrong spot, you may not get as powerful effect as doing a single 1 or 2 lymphatico-venous bypass in an area that is under significant lymphatic hypertension. Let's see. Do you see patients that have other procedures elsewhere, or do you refer them back to the original surgeon? We are happy to give an additional opinion and an honest opinion. And, if it's warranted to have a referral back to the original surgeon, we do so. If there are other things that maybe haven't been entertained or that we can offer specifically at our practice, then obviously we share that with the patient. Do you perform lympha procedure on prospective breast cancer patients that need full axillary lymph node dissection? to prevent and minimize the risk of lymphedema? The answer is yes. I actually presented that. And I didn't use the word lympha, so apologies if that was confusing for anyone. We used the term immediate lymphatic reconstruction, which is the same thing as lympha. We've been doing that for a while. We've been doing that since about 2016. Probably one of the first centers in the country, in the United States, that was doing that. So we have extensive experience with it. We continue to study our outcomes. There does seem to be a risk reduction. There is not a complete risk removal. I think the risk reduction is on the order of about 30 to 50%. So lymphedema may still occur, but it's diminished with the lymphatic procedure, at least in our experience. Is age a consideration for microsurgery? The answer is we do not discriminate on chronologic age. We may discriminate on your physiologic age. So if you're 80 and you're as active as a 45 or a 50-year-old person, we're very happy to talk about surgical treatments. However, if you're a 45-year-old person and you're as healthy as someone who's in their 90s, probably not a good idea, in which case we'd help you get optimized, help you get your health optimized, and and then hopefully get you in a situation where maybe surgery could help. Would you recommend lymph creams and drainage massage oils to reduce edema in the arm? I can't speak to whether or not that helps. Skincare is important in patients with lymphedema, but beyond that, I am not sure I can answer that. Here's another important one. Is treatment covered by insurance? The answer is it can still be a challenge. And believe it or not, despite these procedures evolving and being shown effective over now what are decades, we still can sometimes have some trouble with insurance. Fortunately, I think some payers are recognizing the significant impact that these treatments are having on patients, positive impact, and are increasingly increasingly willing to pay for some of them, certainly at lymphatic centers of excellence. But hopefully we can do more, and certainly L&RN as an organization has been, I think, instrumental in bringing light to this at a governmental level, which will ultimately help with insurance. I think we are nearing the end of our session, but maybe one or two more questions. Common areas, what are common areas where you harvest lymph node flaps to do vascularized lymph node transplant? Some of the common areas are intra-abdominal or the gastroepiploic, otherwise known as the omental flap. The benefit of that particular flap is that the chances of developing lymphedema at the region where you're harvesting that tissue or getting that tissue from, the chance of developing lymphedema is virtually non-existent. However, you are near some vital structures, you're near intra-abdominal organs, and this can be a little bit dangerous if you're not careful. We often will also do flaps from the groin area or the side of the chest where there's some lymphatic tissue there too. But the important thing about that is that when we do those types of procedures, we perform an additional procedure called reverse mapping. So if we're in a region of the body that is close to, let's say, an arm or a leg, we want to try to take the lymph supply that is more adjacent, which is more in line with the trunk drainage, the chest or the abdominal wall drainage, because there's a lot of redundancy there rather than the drainage that's from an arm or a leg. So we do something called reverse lymphatic mapping, which in fact I showed earlier when we were talking about how we do the surgical preventative techniques, the lympha or the immediate lymphatic reconstruction. Okay, I really, really want to thank everybody who attended today. Really enjoyed interacting with everybody and giving this talk. Please reach out if you have any additional questions. Thanks so much.